So, hey, everybody, thanks for coming today. And if you can't hear me, just let me know. I'll project more and speak louder. I've had the opportunity to give these talks maybe 2 or 3 times now on different topics over the years. And I love when you guys ask questions or say, hey, Mike, that makes no sense. What are you talking about? Right? So let's, as much dialogue, just hop in and ask away. So I guess that's my one ask for you guys. Also is, I know this is booked for an hour. I will doubt we take the whole hour.
Thank you.
Unless you guys take a ridiculous amount of time asking questions. I think, you know, maybe 30 minutes, maybe 45, but definitely not an hour. So with that being said, introduction, kind of a little bit about me, and obviously what we're going to talk about today. We'll talk about, you know, use cases, managing the device lifecycle, things to think about. And then, of course, lastly, guys, I always like to have a thing for action, something for you to go back to your organization and say, hey, or at least ask yourself and ask your teammates there, what are we doing to help solve these problems, and are we leveraging our tools? So some questions just to ask the organization. Are we recording now?
Yeah.
Okay, awesome. All right. So that's me, of course. And the reason why I want to put this up here is I spent the first decade of my working career at Verathon Medical. So I started as a sales rep. Then I became, like, I would say, I guess, a little regional manager. And then I ended up running the West Coast for all of Verathon. So if you guys know the bladder scanner with the GlideScope, and you are somewhere west of the Mississippi, there's a chance you received an email from me or someone who worked for me. This is almost 10 years ago now when I left, but where I started the career. And that's where I also I fell in love with working in healthcare. I decided to make the jump from healthcare to technology, and I'll talk about kind of that and where I have kind of this experience, but in a little bit. But when I was at Verathon, I was right out of college, and their old model was we're going to hire people who sold stuff in college. I sold knives. Okay, for Cutco, that's what I did, and they hired me, and they said go sell stuff. So I would drive around Northern California trying to sell the bladder scanner GlideScope. And I remember I go to this one hospital in rural Northern California, and this old ER doctor, and you guys know who this person is, he says, Mike, we don't need your product. That video laryngoscope is a piece of crap. And this is, you know, maybe 2009, 2008. And he says, we don't need this. And I said, you got to buy it. We don't need it. So then I ended up twisting his arm because he was the chief, and then some of the other ER docs wanted it. So then about a month later, I go back into his office. Or I go back to the hospital, excuse me, check the ER, how's the device going, have you guys used it? And he says, hey, get in my office. And so when a chief tells you as a salesperson to go get in your office, that's always a bad sign. I'm sure you guys, in your experience, know that too. And then I sit down, and he says, Mike, I need to apologize to you. I said, why do you got to apologize to me? And he said, last weekend, we had some teenagers who got in a car accident, a girl came in, we could not get her tubed. I said, get in the GlideScope. I intubated her, and she got discharged from the hospital 2 days ago. If you hadn't had sold me that device, she'd be dead. And that obviously was you know, as a 24, 25-year-old, that was like, oh my gosh, like I'm just selling something. I don't realize like what I do actually affects people's lives. And then what I realized throughout my career, and also with what you guys do, is every day you guys touch a piece of equipment. Every day you have a conversation, help a clinician. It saves lives, because of what you do. If you guys don't have the tools, if you guys aren't enabled, right, aren't supported by your organization, human lives suffer. And there are people that you don't know their names, you don't know their families, you don't know their kids, right? This girl, I don't know, she's probably married, maybe with kids now. I have no idea. And she talks about, oh, remember that time one was died in this car accident, right? Like there's no connection between us, but I still think there's like this amazing thing about what we do in healthcare. And that's why I'm so excited. I've been spending my entire professional career in healthcare, and also now what we do here at Asimily. So from there, I wanted to get in technology. So I joined a company called Connective, which is a CMMS. Some of you guys may have heard of it and used it. That was part of the Accruent company. I think they've sunsetted the product from that. I was at Accruent for about a year running the healthcare business. Then I joined a company, worked closely with ServiceNow, joined a company called ePreop, which was care coordination from the surgeon's office to enhanced recovery. So really seeing that entire life cycle on the clinical side, pretty in depth there. And then from there, I had the opportunity to join Asimily. I've been at Asimily almost 5 years. And so it's been a pretty great run, but also going really deep into thinking, how do we think about devices, and how does it affect patients, and how does it affect looking for workflows? And so really that's what the focus is kind of what I want to talk about today, is this holistic view. So with that, what I just said there, let's kind of jump into it. So when you think about device cycle management, you know, whether it's, and this is, we think about the inventory and visibility, you gotta know what you have, right? If you wanna figure out how do you manage it, how do you secure it, you gotta know what's on the network, what it's doing. You also wanna know who it's talking to, how it's on, off, in use. You also understand what your real risk is. Not the mythical risk that somebody in IT thinks you have on some device, or the risk that some vendor said, hey, you gotta replace this piece of equipment because it's old, all right? Or you gotta buy this warranty because it's old. I'm gonna give you some examples why that's often not true, all right? And then of course you're gonna have to understand what you can actually do to secure those devices. And when you think about replacing them, what you wanna do around the organization around when that device is doing something it shouldn't do. Like why would an infusion pump talk to a security camera or a printer? Why would an ultrasound be sending data to Bulgaria? You know, these are things literally like my company, we see almost every day and across our customer or install base now. And so that's where these things are scary, but you guys are gonna understand what's normal, what's not, and what to do. And of course, the other thing that's governance, risk, and compliance. From when you're looking at buying devices, right? How do you think about get ahead of this problem of making sure you're buying the right devices, you're standardizing to the right devices. You're also looking at how do you secure them proactively, and then how do you monitor that throughout that device, and how do you stay in compliance with the new security rule, which it looks like it actually will become a rule. With how these types of things are going to become much more of something you will be asked, and the cyber insurance companies will be asking for as well. So we're going to cover a bunch of use cases that touch all these. So the next thing, guys, we think about those different functions. We then got to think about this team approach. And I'll give an example of a customer that basically said, Mike, to tell us exactly what to do, and really not me, really more of our team, okay, is they said, Asimily team, how do we actually solve this? And I think I'll tell you exactly what they did. It was pretty impressive. But right here is the end users. When we think about every device in the facility, if the nurse does not like it, if the doctor says this doesn't work for me, or it's in a clinic, I can't get high enough reimbursements. How many of you guys have physicians who are in clinics who are paid off like RVUs, or they care about what the reimbursement rates of the devices? Anyone? Okay, I see head nodding. Okay. So this is an important thing, right? What does that work for? Obviously financial. You're the person sitting here. I got it. There's every hospital. Obviously, you guys running off maybe 2% margins if you're lucky, or you're maybe constantly losing money depending on what kind of patient population you see, and you're being subsidized by the county or maybe another organization, right? So your financial is like, hey, what are those capital and operating costs? How much does it cost me to buy? How much does it cost me to maintain? The reimbursements and expected lifespan of that device. And then those are what they're going to care about. Then, of course, you guys, support and maintenance. Can you guys PM it? Can you do corrective maintenance? Does the vendor require you to get special training to service the device? Okay. I mean, one of the more ridiculous things what some of what the OEMs are trying to do for the right to repair. So I'm very much on the you guys should be able to fix anything side of this. That's another tangent. Anyone who knows me, Dusty, know me. I go down tangents sometimes. I'm going to try and pull back on some of this stuff, but I get really fired up on that because it's a ridiculous thing. So the next one, of course, is a device. Is it 10 years old, 15 years old? Well, is it still supported by the manufacturer, or is there some other way I can get the parts? Can I still keep this thing working so it still makes sense for the end users? They're happy. And financially, is that cost to maintain it makes sense, right? So these are the things we think about. And of course, this next piece now, becoming bigger, is cybersecurity. Can we secure it? And what can we do to secure it that does not break the bank? So obviously the big thing here is everyone has to be on the same team, right? But also you gotta have the best data to make the best decisions. And what I've found is that even when you have everyone with the best intentions, if you have bad data in, even if you have tooling, you're going to make not optimal decisions or bad decisions. And so it's really, really key to think about, well, what actually does matter? So that's when I'm going to go into these 4 or 5 examples I have to show you what some people have done. All right. So when we think about this people, process, and technology, Asimily, we are a technology company. We do some services, so we help with process and people. But really, when most of these types of tools, or when most people say, hey, I can't be successful here, it comes down to the people and it comes down to the process, right? So if you have a tool, you'll probably be in a better place. Obviously make sure you have we'll talk about different tools you want to have too, right? But the people and process is key, and that goes back to bringing those 3 pillars together, having everyone be the right stakeholder, and then thinking about these different items here and really push forward from when you're looking at buying the device all the way through when you're going to actually decommission it. So when we look at this, right, what are the first things we want to do? We want to establish that governance council, that team. We then want to make sure we see everything and we have good data on our network. So part of that's making sure we have a CMS. How many of you guys feel good about the current CMS platform you guys use today? Couple hands? Okay. All right. Do most of you guys feel like the data is iffy in it? Yeah, right? Okay, all right. So that's the challenge. How many of you guys feel good that your health system has a good idea on your spend on parts? Okay, see a hand, right? How many of you guys feel pretty good about that you actually know what is on your network? How many of your devices are connected versus not connected? Okay, so we have a couple. How many of you guys feel good about what the risk is of those devices? All right, maybe. Okay, how many of you guys feel good that you can actually do something with that information? Okay, and what about, how many of you guys know the utilization of your devices? How often they're used, who they're used by? I don't know. That's awesome. Okay, so as you can tell, guys, it is a hard thing to do, but having the tools in place to support all those processes helps you make great decisions. And of course, the last piece here is when you have that, you can manage vulnerabilities, risks, make better capital equipment purchasing planning. All right, so this is, now I'm going to jump into some real examples. Let me stop real quick for a second. Any questions so far?
Yeah,
Yes.
what's HDO stand for?
Health delivery organization, health system.
Okay.
Just a small acronym, but great question. Any other questions? Do you have a question? No? Okay. All right. So this is an example. So we have this is from one of our actual customers. How many of you guys have a Brilliance? Brilliance. So this is an older device, right? It was running XP, and the vendor said, hey, you got to pay us 70 grand to upgrade for software. You know, and this hospital's like, my nurses, you know, my nurse a little bit more than that, but he was like, that's like a full cost of a biomed tech, a brand new one, a BMET 1 for me for a whole year. And he's like, is this thing worth it? And so he went into Asimily and he said, hold on, we can spend 70 grand. It doesn't improve the clinical efficiency, doesn't help me get better parts, doesn't do anything. It's just an upgrade that makes IT happy. And I changed my risk from a 4 to a 5. The max risk is a 9, still the same. But if I put a couple of simple controls in place, it's exactly the same. And this is a classic example when you guys are on this device, he then was able to then take this data, push back against IS, who said automatically, we always got to replace old equipment, or we always got to pay for patch upgrades, or we always got to pay for warranties from the OEMs or these special service programs. Guys, 9 times out of 10, frankly, 95 out of 100 times, you don't need to. And with the right tooling, people and processes, you're like, there's not value for those things. And I'll show you some more examples. And so he was able to take this, go to his leadership team, and they said, yeah, we're not going to buy this because it didn't actually drive anything for the organization. And now the one thing I remember, his biggest pushback was the chief of radiology of a small hospital, but still the chief, because the chiefs are always very powerful. And so he then saw him in the cafeteria and said, yeah, I just went and literally pulled up my laptop and showed him and said, this is not more secure. We don't need this. I know we like vendor. We're not going to get rid of the product, but like, we don't need this, and we need to send you around other places. So able to work through that organizationally too.
Were you just associating like the CVEs of the particular operating system and the transition in order to like correlate that risk, or?
Yeah, so what Asimily does, and just is, and this is I would say it is very unique for how we've done it, is that we take all the known CVEs for devices, taking let's say those 2 operating systems and on that device with the MES2s, SBOMs, bunch of information. We then identify what is exploitable and not exploitable on that device and in that network. We then take something called the MITRE ATT&CK framework, AMI 57, and a bunch of other different things, and things that are proprietary. We also have a patent around this, or several patents actually. And so we are able to, with extreme accuracy, tell you what's actually exploitable and what's not. And from there, we're able to tell you what your actual risk would be. So that 4 and those 5, those are the highest risk CVEs that could be exploited on that device. So you had 9s, those are bad, those are the worst of the worst. Most information security professionals are going to tell you, hey, if I can get to a 4 or a 5, I'm good. I don't care. And so it's not worth it. So that is essentially what they are able to show. And so part of this also is how do you get to a 4 and 5? Well, you got to put some control in place. You got to do some level of something on this. I think on this one particular, something to the device. You had to shut off some services physically as you touch it, which is where you guys come in, and then also you had to apply a small part on a network through the firewall segmentation policy. Any other questions?
So you would analyze the risk for that specific operating system. What about the future upgrades for specific software or modality or user interface?
So you mean if they came out with a new product?
So let's say they made the decision not to upgrade it, but then there's a new product coming out for the specific modality, let's say for the user.
Totally. So great question. So this is is anyone from MD Publishing here? Because I want to keep it very educational, right? But so we have something called ProSecure that does that, right? If you're looking at buying some piece of product, you can basically type in those modalities and it'll tell you exactly what your risk is and what you need to secure it. And so if, hey, does us replacing this fleet of devices with this newer model make sense? Or do, us expect, so there's absolutely, you can just, it's relatively straightforward.
So an old device with the newer operating system can offer different features, right?
Yep.
So will you analyze those features too?
Yeah, if they increase the risk of the device, right? So it could be that it has a new feature, but actually it's still running the same operating system. It's still communicating on the same ports. So not much actually from a security point of view, or even like a device utilization point of view has changed. It's just that you can now do X number of different procedures with it because you added an ultrasound probe or something. I don't know, but maybe not the best example, but does that make sense? Okay, awesome. Any other questions? Okay, all right. So this is another one I like to always tell people about. So one of our multi-hospital health system, they were looking at making a major infusion pump purchase. And the HTM leader said, I don't understand this. Like, he felt like they had more than enough infusion pumps. He looks into CMMS, says, I got plenty of infusion pumps. He looks at Asimily and he's like, we're not even utilizing them that much. So if you can see right here, here's an example of like, this is what's used and unused, right? So you can see like relatively low utilization. And of course, then he can even find them too, right? To the mapping functionality. And he's like, I don't think we need this. And the nurse is like, yes, we do, yes, we do, yes, we do. So he goes to a CMMS, he looks at Asimily, and he essentially realizes that it was something like 30% or 40% of his utilization pumps had not been turned on in the last 3 months. They were sitting in nursing offices. So he goes to the CNO and says, hey, CNO, you guys, I'm not going to sign up on this. It was like $1.2 million PO. I'm not buying them. We do not need them. Your team, you need to send an email to all your nurses. Go look in the bathrooms, go look in the closets, pull out your infusion pumps. So and he showed her the data from Asimily. From that, she sent out that email and identified, you're right, we don't have an infusion pump issue. We have a nurses hiding devices issue. And this is a small example, but it's actually a big one because $1 million is still a lot of money. Plus, it's that soft cost of taking those devices and putting them out in the field. Something else that you guys do think about that people, process, and technology is often devices can be underutilized. And I have another example of what a customer did recently. I'll tell you guys about too. Is do we have devices at the right locations? Or are we replacing devices? Do they really need to be replaced, or do we just need to sunset what we're doing there? And so there's a bunch of things you think about it, but it's really powerful when you think just on where devices are located, especially when you come to a multi-site, multi-location health system. Any questions?
Utilization is just based on amount of network traffic.
So yeah, so it's network traffic is what we're seeing, and so it's on, off, and use, right, is what we'll do. On like clinical devices, we'll actually, and this is pretty common for all the tools in our space, we'll be able to tell you what devices are actually done. We'll even be able to tell you who is using that device at that time through our AD integration. So we'll see that Tim is logged in the ER, and then he was logged in to maybe the roaming ultrasound tech, right? He's in the ER, the next day he's in the operating room, and then the third day he's at an imaging center, right? Like you'll actually be able to see and track what users are doing what and where as well. But there's quite a bit of detail you can get from it. Did that answer your question?
What, just quick question. So like Bebrons have dose track, Baxter's have device view, and Lawyers have something pretty similar. What is the benefit of like looking at it through harness, it's a little bit easier for the average user to interpret?
Yeah.
Okay.
So I think that's the benefit of having a unified platform. Now we actually we can integrate and pull data, but I think some of the better examples, frankly, are when you look at your like your ultrasounds,
Yeah.
right? Your mobile X-rays, stuff like that. That's mobile. It's on the network. It's really expensive. And then you can kind of say, like, do we have the right fleet management? Some chief's like, well, or you have some doctors saying if they get billed per RVUs, right? So they want the more they bill, the more they make, right? These doctors, they will push for these purchases. And I will say I have friends who lead sales teams at GE, Philips, Hologic, Carestream. I have friends in all these organizations that run sales teams, and that one of their playbooks is go to the clinician and figure out how they get paid, and push that when you're trying to sell new modalities. Say, hey, if this device goes down because of cybersecurity, you got to upgrade, right? So they push. So then they go. The chief, who is very powerful often, right, will push that way. And you're sitting here as trying to be a great steward for the organization. Does that make sense? But you can't push back. Your CFO can't push back unless you have great data, right? And that's where tools like Asimily come into place, can really help you with that, to have that conversation and push back against that, because there is a lot of those different dynamics. So this is another great example. And this was actually this was actually an amazing conversation. I was on a call with a customer, and they were sitting there saying, hey, doing like a CS call, and we actually were doing like a quarterly review, so some of the executives were on. And then we said, hey, you guys have these CTs, they're a little bit older, we always recommend, do these, next quarter you guys should put these controls in place, you're gonna reduce the risk, and you'll be good, but they're old piece of equipment. And the CFO was on, he's like, hold on, I just signed the PO to replace those. So and I guess the COO had to sign next, and the CEO. So literally, he was messaging them on the message them right now not to sign, and they ended up not replacing the equipment, because the entire reason for the replacement was the chief was very worried about cybersecurity risk. But the chief did not talk to the CISO. The chief didn't, and the CIO was really nice CIO, but sometimes CIOs aren't as active. Sometimes they're more clinical than they are security, right? So he didn't actually look at those things. He didn't know. So this is where they put a pause, they stopped it, and this is the time the hospital was bleeding like $1 million a month, right? So this is where he's like, this actually, us delaying this purchase, this was like 2 or 3 years ago, and I believe they're still in the network now, it delays that. So even if you can look at a purchase, secure a device, so you delay a purchase for a year, 2, 3 years, your financial leader will look at that, and that will help them on their books and their financials, when they think about how their capital allocation goes. And I have an accounting minor. I almost pulled up some accounting numbers for you guys on this one. I thought that would just be going down a little bit too deep. But there's a lot of financial reasons why. If we can extend the life of any of these devices by 1 year, the huge ROI does for the organization, just by 1 year. So, and that comes back to, obviously, you guys being able to fix them, it working for the clinician, and et cetera. All right, this is one of the more recent ones. This one's awesome. I think it's amazing. So one of our customers, regional health system, they had mammography, I can never say that word properly, and they had several clinics. They had a decline in patients, and they're like, and on the business operations side, they had a decline in patients. They also need to hire more clinical staff so they could see patients. They had multiple locations. One of their locations had old equipment that, frankly, because of it was in a clinic, it was hard to secure. They didn't have a NAC. They just had firewalls. It was far out there. There was a bunch of reasons why, like, there was some security risks, and they said maybe we should replace them. Well, the HCM leader of this organization has done a pretty good job of elevating their role. And so he was looking at Asimily saying, hey, do we even want to replace these? And then he also had a water cooler conversation saying, hey, we're thinking about downsizing this department, the mammography department. Well, they're looking at replacing the machines, right? Pretty expensive, over $2 million. Well, he goes and looks in Asimily, and he's like, hey, and this is just data to show you, like, utilization shows that these guys are only being used 10% of the time. So what they ended up doing is they ended up choosing not to hire that basically shut down an office, so they ended up not hiring a clinician, so they saved the cost there. Not hiring like 2 clinician support staff, plus not replacing the equipment and shutting down a office building and getting rid of it. Where the CFO said, because it was almost like the chief was like, no, you got to buy this, right? Because he wants a bigger department. And mammography, anything dealing with these imaging, right? Those are big revenue generators, but they were able to clearly say, hey, like this doesn't make sense. And oh, by the way, all the offices were within like 30 minutes of each other. So it wasn't like a huge deal. Like, do we need 3? Someone can drive a little bit farther, right? So when they kind of think about the competitive market of individual stakeholders, so they're able to close the office, save this literally, capital, then of course 3 million plus in operating costs, and obviously more than paid for Asimily, but also it's a good example of helping the business make better buying decisions as an organization. And you guys in HTM, you have so much knowledge and so much power. Outside of people, the second most expensive thing, right, for health systems, other capital costs, are really your equipment that you maintain. You have all these keys to the kingdom, and it's taking the data and then going to the different stakeholders and showing them. This is a really good example where someone, just like all of you, was able to go there and save the organization a ton of money. Obviously, he got a big kudos from everybody from this one. Cool. Any questions so far? No. All right. This is a case study from one of our customers, and this is when I talk about, hey, that process I talked about earlier, what's possible. This is more focused on a little bit more on risk reduction. There was actually quite a bit of capital savings too. They really pushed through this, but essentially they had a different solution. They didn't use Asimily. They weren't happy with it. We ended up doing a replace, showing how our platform was better, would actually allow them to bring their teams together and truly reduce risk in their organization. They had extremely high risk. They had an audit. They had a finding. Even though they had a tool in our space and they had been investing time to fix it, what they found is that they were mitigating a lot of what we call phantom risk. So they were replacing equipment that didn't need to be replaced, or they were mitigating CVEs that didn't need to be mitigated because they weren't exploitable. And this is like a big issue, frankly, is what I will say in the market today, is that when it comes to these medical devices, half the CVEs that are out there can never be exploited on them, ever. You gotta know which half though. That's the secret sauce, right? But half of them can't be. And so if you just say, hey, CVS3, Windows 10, communicates on the service, we're good, but it's not, because you gotta know how the device works. You also gotta know how it operates at your location. And it's really key. And this is a multi-hospital system, so you'd have an ultrasound that had a risk of a 7 or 9, let's say, and then that same exact model, everything's exact. They bought it the same day at a different hospital with a risk of a 3. Because of how it was configured at each location. You have, and those things are really, really key to understand to make the best decisions. So they unfortunately were spent several years going down the wrong path. So when they came down to Asimily, we basically were able to show them what their true risk was, show them how they would use our platform to reduce risk, and they essentially over 8 months were able to, how many CVs? Something like 50,000 CVs reduced. I think so it is, over 800 anomalies fixed. They had a lot of devices talking to each other that shouldn't be talking. I know they ended up, I should have, the person who we were doing the case study with, I didn't get the exact dollar amount, but in the millions of dollars, they were able to justify saying, hey, we did not spend, we did not replace. Warranties they canceled with OEMs, saying we're not going to renew this cybersecurity warranty, we're not going to buy this warranty because of the data and something. So really, really powerful. And when you think about that process I talked at the very beginning, when you have the process in place and you have the right information, all those use cases are frankly applicable to this customer, right? I'm sure they had similar, some kind of cases here. All of them do, and there's some other use cases too. But it's absolutely possible to massively reduce risk in a time-efficient manner for you guys. So, and this is Hogue in Southern California, another customer talking about different things we were able to do with their team. We actually talked with Hogue, and he actually gave a talk about how he's been using Asimily at the MD Expo in Temecula. So he talked to us about that. All right, this is the last slide. I told you guys we were gonna get done a little bit early, all right? So the questions you guys should go back and ask your team is, what team are you guys building? Not just you, but IS, IT, networking, your capital equipment planning, the clinicians, to bring together to solve this problem. Then it's how do you guys remediate vulnerabilities and malicious behavior today? How do you guys approach that? And is that the right approach? Do you guys need to make some changes? Next thing is that how do you guys justify hiring clinical engineers for cyber work? That's something actually I should have talked about on this previous slide is Bob at Hogue was able to take what the information in Asimily and what they've been able to do to justify hiring more staff for his department because IS is terrified of medical devices and fixes. Does anyone have their information security teams really scared of medical devices? You guys see that? They don't know what to do. And so that's why they're often, they don't know. And so what their first reaction is, let's just buy the latest and greatest. Because if something bad happens, it won't happen to me. Well, that's not, you don't need necessarily need to do that. And if you are a cash conscious organization where you don't have a lot of money, which is most of the health systems, being able to look at that is really key. But of course, being able to justify more employees to speed up that hamster wheel for savings and justify it to the CFO is really powerful. And that's what somebody's been able to do. Next one is how many hours a week are you guys allocating to work on this challenge? And so think about that, right? If you don't put focus and time on it, are you gonna be able to improve not the cybersecurity piece of it for sure, but also are you gonna be able to improve this overall lifecycle management and something to really think about? And of course is, do you have the best tools to give you the best data? Right, and this is where, coming from the old CMS world, you would go and help people change from one vendor to another. And obviously, is that tool the right tool for your organization that you're using? Is it the tool that's gonna help you give you the best data? Is that company the right company for you to work with? You know, people leave organizations. So a company that was amazing to work with 3 years ago may not be the best company to work with you today. So think about that kind of stuff and constantly holding your vendors accountable for sure, so they can support you. Okay, I'm done. Any questions you guys have?
How do you think, so we have a really big cyber team. Unfortunately large because I think there's sometimes a disconnect.
Yep.
And so what's the best way to actually integrate this within like the service delivery workflow? Because I'm constantly kind of fighting to be like, look, don't deploy these work orders, wait until the PM because this is a lower like risk. And by deploying my team twice, we're actually wasting effort. Like, do you have any suggestions? Because you're highlighting the need to focus on that. How do we collaborate better?
So I think that goes, that first part is that like you got to sit down and like have that conversation. And I know the organization you work for, I understand why that can be a challenge. Okay, I totally get it. So there's a challenge with scale, right? Where things get honestly less efficient as you get a little bigger. But I think the biggest piece of it is just pushing back and then showing in your CMS platform, hey, we're going to add this as one of the tasks they're going to do for the work order. The PM is scheduled for 4 months out or 6 months out, or next we're going to do it in 9 months. Is that acceptable? Right. And then I'm assuming you probably already had these conversations, knowing you.
That's right.
Yeah. And say, yeah, that's what we're going to do. You know, and then I've had some customers, some HM leaders where like they can bill other departments. I don't know if you guys can do this, where like they've said, well, all right, fine, then I'm going to bill you for my team's time. Okay. Now, I don't know if they're going to pay, but you can say that's what we're going to do if you're going to create that, because that's going to cause all the downstream effects. And this is a low risk. And the question, though, I would also say is that if it's a low risk, why are you fixing it? Exactly. Because I told him, and this is where I think that everyone. So in cybersecurity, and this is something that bothers me about the industry, because I before that is, you know, in healthcare we say, hey, let's do no harm. Do you really need that surgery? Do you need that procedure? In cybersecurity, especially on the vendor side, it's I want to show you so much risk and scare you to buy my product. Okay? I always say like that to me, like everyone has risk, okay? And there is real risk that you have to take care of, right? But we all know like, hey, you got high blood pressure, you got to work on it, right? You got to think about those types of things, okay? There is real risk out there, but when it comes to medical device, like if it's not high risk, unless it's very easy to do to mitigate low risk, it comes a point of diminishing returns, right, for the organization. Unless you have unlimited money and unlimited staff, right, it just doesn't make sense. So that's where I would just definitely push back and make the IS team justify you, because what they could be is that they're so scared of any risk, they don't understand medical devices, they just want to replace it. They just want to replace it, yes.
Just an observation, what I think I hear you saying, I've seen this over and over in my career, is it's a misalignment of incentives. So oftentimes, the HDM group is incentivized to get PMs done.
Yep.
Just to oversimplify. Your cyber team is incentive to close every risky door, right?
Yep.
And so when the incentives are not aligned to the end goal of taking care of the patient, non-disruptive service, that's where these conversations become extraordinarily difficult, because I'm doing what you, the organization, sent me to do. If you want me to do something different, then incent me differently. Tell me, here's what I want you to do.
Totally, and it kind of goes to this thing is justifying a clinical engineer for cyber work. What we've done, we've also, as Asimily, we have a services team, because some of our customers are like, can we just outsource this, because it doesn't require a full-time FTE sometimes, depending on the size of your organization. I should say, some organizations definitely require full-time FTEs, okay, right? Just depending on the size. But someone who can straddle both fences, and if they can be dedicated to that, that speaks both languages, because part of it also is, how, you guys look at risk, you're thinking like safety risk for a patient. I don't want a patient to be electrocuted during surgery because of a faulty wire or something. Maybe it's not a great example, okay? But you're thinking about patient safety risk with medical devices. Cyber is purely, I don't want a bad actor to touch those devices. And another use case I almost put in here, but this one's pretty terrible, is how many of you guys, has anyone ever had like a device randomly malfunction, you can never figure out why it goes on and off, like a patient monitor or an ultrasound? Have you ever asked IT if they've scanned that device? So I've had multiple cases. We had a customer of ours. They had Tenable, the vulnerability scanner. They were switching to Qualys. Okay, Qualys came in. They had a managed service doing Qualys. The new managed service decided to use Qualys and scan every IP on the network. Okay, they were in the OR doing a cabbage. OR goes down. The Qualys guy kept, why can't I, because they get some feedback, like I'm not exactly quite sure how Qualys works. Basically, the guy kept trying to ping and brought down. Thankfully, the patient didn't die, right? But I guess the HVAC went off, likely the patient monitors weren't working, all the communication stopped. They were a very connected hospital, where they are, through basically IT not understanding the real risk and not having that team approach to properly doing it. Now, obviously, thankfully that didn't happen. One of the big things I would say, like if you do have a tool like ours, one of the first things we always do is, okay, what's your scanner? If you have an active scanner, and let's make sure we're not scanning medical devices, right? Let's make sure medical devices are on a guest network. That happens all the time, by the way. Okay, you have a vendor comes in, you have a third-party OEM. One of our great friends from imaging will come in and they'll work on a device, and then they'll put it back on the guest network because they just want to get on the network communicating, no one complains, and they leave. Or a vendor, one of my friends, right, from the sales side, they want a demo product. They don't want to go through the pain of putting it on your corporate network. The doctor wants to use it. They're trying to close the deal by the end of the month, or the end of the quarter, what have you. It's on your guest network. All cyber risk. It also can be patient risk if it's on the guest network too, for a whole host of reasons. So these are things you want to have visibility into as an organization, and it's an important stakeholder. So like I said, I have many stories I can go on and on about but I appreciate you guys' time. This is amazing. I was like very excited. I didn't know how people were going to show up. This is great. 8 a.m. So thanks everybody for filling the room. Any other questions or comments, or like your own experiences? Maybe we go to the team. Yeah.
What is the interaction with CMS?
So I don't know if there's one we don't integrate with, but there's. So it's pretty seamless today. So most of them actually, on Asimily, how we got most of our integrations now is you actually can install them without ever talking to us, which is amazing. It's actually really cool. I had a customer so hold on. Is there anyone here? Okay, is anyone from Ames in here? No? Okay, all right. So I had a customer turn on the Ames integration like the other day, and they didn't tell us, which normally they tell you, and they didn't tell Ames. And all of a sudden, like our engineering team was like, hold on, we're getting all this, because we will pull in like all the data in Ames. And then we can also push all the data in Asimily in Ames. We push tickets back and forth. It's very similar flow. There's some CMSs have some limitations, right? But pretty much the same for all of them. And they just turned on and started using it. Like, oh yeah, it's great. And they had pulled that mapping function I showed you in Ames. It's really cool. So, but it's pretty fun when people do it. But I would say you always want your text working out of the tool they're used to. So the idea is get the information assembly inside of your CMS. That's the ideal state.
Piggybacking on that, are you able to see the data and correlate that to equity or whatever that you may have? Be able to tell that devices are update
I mean, from a recall point of view?
from recall or the most update software?
Yes, so absolutely we'll tell you if something does not have the most updated software and what it is. And so if a patch is available, we'll always tell you if there's a patch. If, you know, if there's a recall on that device, we'll tell you it's a recall. The only challenge is that if we're not integrated with the CMMS, we might say, hey, there's a recall on this device, but you mitigated it. But we don't know that because we don't see all the recalls on the network, right? So that's my one caveat there if we're not integrated with the CMMS, but it's, you know, it's extra data.
So
So
if you're integrated all of the data from the network, you can see the discrepancies as well between our CMS and what you're actually seeing on the network.
1000%. Yeah, and it's actually pretty, we'll see, we definitely, people will use Asimily because we try and integrate and all of a sudden, let's say you match 90% of the devices, there's 10% you don't match. Well, it's because someone fat fingered the serial number. Right? Oh, okay. So it's wrong on the CMMS, but actually we have it right. You know, because I will say like what we have is just from the network. Now if the device doesn't transmit a serial number, well then like how do we match? And there's 4 or 5 attributes we use to close that gap.
So what is your average serial number match? You don't tell me what's on your inventory.
So like how often we pull serial numbers, you mean? So it only pulls, there's some devices that never gets sent on. Okay. I don't know what the percent, if there's like a percentage I can give you, because I think it is dependent on what types of devices you have. But so I believe our secret sauce at Asimily is amazing.
Yeah.
We do a really good job. And when other people compare us to other tools, we do 2 things. We do deep packet inspection. We use AI and ML, all right, together, which most companies either do one or the other, or they actually only do one or the other. And so that's how we start. And so because of that, we've been able to get really deep. So if you can get it, if it's in the packet, we're gonna get the information. So that's what I would say. Like if it's in there, we're gonna get it. If we don't get it from that, we're gonna integrate with the CMS and we're gonna get it from there. Yeah. So that's you know, and I'll stand on that. But there are devices they will never transmit on the network, so you'll never see it. Other questions? Okay. All right, guys. I know I told you I was gonna keep this short. I appreciate all the conversation. If you have more questions, I'll be sitting at our little booth, happy to talk more. My email is really easy. It's mike@asimily.com. So you can always look me on LinkedIn. Happy to answer anything and appreciate it. All right. So thanks everyone.